Dear students, we will discuss a common operative procedure today. Just see what is this. See that there's a bipolar here, and some tubular structure is here, and other it's definitely a laparoscopic procedure. You can see this laparoscopic view. It is very typical, and you can see cecum and other area also. So this is laparoscopic appendicectomy. Currently, it is the gold standard. So MCQ question is, what is the gold standard procedure for appendicitis? Is laparoscopic appendicectomy, not open. Of course, if you find difficult, then convert it. Because you need to know the other approaches which you still practice in many places, and it is a standard, at least in olden days. You should know Gridiron, McBurney incision from lateral 1/3 to medial 2/3. Then if you extend laterally with the muscle cutting in the difficult appendicitis, that is called as Rutherford-Morrison incision. If you extend medially, it is called Fowler-Davis incision. Crease incision with fitting incision, it is called as a Lance incision. Then right paramedial incision, midline incision, then laparoscopic approach. The different approaches we were used for the appendicectomy. Approaches for appendicectomy is a short note asked, MCQ question, Viva they will ask, Oxy they will ask. So all these different approaches you should know. So advantage is going to edge over the open procedure when there is a doubt as it is it the visualization of entire abdomen. You can scan entire abdomen, you can see, especially in female differential diagnosis, ovarian cyst, ectopic, twisted ovarian cyst, even everybody, whether even male or female, sees perforated duodenal ulcer mimics appendicitis. And you know that you do remove the appendix in a perforated duodenal ulcer which is missed in open method, then peritonitis will continue and you may lose the patient. So that is the important point which you have to remember. So where laparoscopy will not miss it. You know whether it's appendicitis or not. You know other problems which fit along with or without appendicitis, which you can come across. You can identify macula diverticulum very easily also. There is an advantage. You can scan entire abdomen cavity. That is the most important thing. Where technically difficult in burst appendix, cost factor is a limitation in a peripheral area, village area, poor patient, then that is a problem. Other is a standard, remember, it's a gold standard. There is no doubt it is MCQ question. Always you have to say laparoscopic appendicectomy. So under GA it is done. Catheter may not be passed depending on the situation. In a burst appendix you may have to put, and umbilical port 10 mm for the camera, 30-degree telescope is used, and laterally, left lateral 10 mm scope is used, which is with the 10 mm with the 10 to 5 mm reducer, where it is used for the dissection and also used eventually for retrieval of the appendix. Another suprapubic 5 mm telescope port for 5 mm instrument for dissection, and so we dissect it bipolar, use the bipolar to fulgurate the appendicular artery, reach up to the base. That's very, very important. If you don't reach up to the base, long stump appendicitis can occur, and it will be again same pain symptoms will reappear. That will be, then may have to reoperate again such patient. Reach up to the base, then put endolobe made up of catgut or vicryl. 2 endolobes proximally should be placed, then distal part should be cut. But if endolobe is not able, you can use intracorporeal suturing and transfixation like it also. There is no need to burial, there is a standard thing currently even in open method. And you can create endolobe with the standard 2-0 vicryl also and push it into that. Then give a good wash and suction if there is a collection fluid in the paracolic or in the pelvis. Otherwise, there is no need. Normal saline wash through the suction apparatus, you can use it. And close the 10 mm port sheet should be closed. Other things, only skin is sufficient with the synecdoche gum or sutures. And send the appendix for histopathology report. And next day you can send the patient home with the oral food and some antibiotic and analgesic. And it can be done as a daycare surgery if there is not burst and peritonitis is there. If sepsis is there, you want to send it to daycare, you have to admit until sepsis is under control, because we need intravenous antibiotic in such patients. So that is about the laparoscopic appendicectomy. Complications are port site infection, collection pus, bleeding, if you don't, from the appendicular artery fulguration is inadequate, leak, same thing like in open appendicectomy procedure. So turgid inflamed appendix, see that bowel vascular injury can occur because major vessels are very close there. You can see iliac vessel, ureter you can see many times, all those things. Cautery burn to the bowel. So very, very careful while you use the cautery in laparoscopically, because bowel, if you touch a tip, if you touch the bowel, adjacent bowel, inadvertently without knowing, that time you won't feel anything. Eventually necrosis occurs and causes perforation in peritoneum. It's known to entity. It may cause the lead to the mortality also. And there such a situation, you have to open the abdomen, laparotomy to do, then close the perforation, put a drain and come out. And you should avoid that one, important. Ligature slipping, fecal peritoneum, fecal fistula. So the complications of laparoscopic appendicectomy. Again, MCQ question, oxy they can ask, Viva they will ask. In a short note, laparoscopic appendicectomy, you have to write these complications. All these complications have to be written. This is very, very important. Because the turgid appendix is that, tortuous, turgid, inflamed, redness is there, is a cecum. So that very typical here. This is the typical look of the laparoscopic appendicitis, turgid appendix, inflamed appendix in appendicitis. So answer the MCQ. 30-year-old male posted for laparoscopic appendicectomy. On table, a mass of 2.5 cm was seen near the base of the appendix. What would be the next line of management? A. Appendicectomy. B. Right hemicolectomy. D. Total colectomy. D. Appendicectomy and abdominal seat. So students, find out the right answer. Put it in the comment box. I'll get back to you. So students, I hope you have understood this laparoscopic appendicectomy very well. Thank you so much. So students, go through my SRB's clinical methods in surgery, which has got a video lectures of each topic. So many topics are covered. Every topic as far as CBM syllabus is covered. How to examine the patient. Swelling, ulcer, arterial disease, venous disease, thyroid, breast lump, mass abdomen, briefly orthopedic, every system, whatever your required thing, everything is covered. There is a video of how to examine of each topic, and principles of examination is good, and differential diagnosis in the table format is given, and briefly investigations. Suppose treatment is not a topic will be covered in a clinical method examination, remember, and many photos of the most of the conditions with the illustration. Photos will tell the clear idea about for the students how exactly condition looks like. So covers everything with the beautiful photos, and it also gives the instruments, specimens, then operative surgery briefly, everything is covered. Small images also it is covered. So it is more than sufficient for all undergraduate, postgraduates of any system to learn very basic required thing for the surgical field is clinical methods. So please go through that and purchase that and make use of it. My SRB's manual of surgery is very popular. It covers theoretical aspect, everything, principles, treatment in detail, briefly technical aspect, and with the photos, illustrations, quotations, all topics with the specialty, urology, cardiothoracic, neurosurgery, and operative surgery instruments. Again, it is covered in this book also. Every quotations, and you should worldwide also, including our country, everywhere. And please, you can make use of it. My operative surgery book, SRB's operative surgery atlas, that is a 2-volume book, covers in detail operative technique of surgery, all surgery, small surgery, major surgery, everything with total around more than 10,000 illustrations and photos. It gives very good principles and technical, step-by-step technical aspect. Very, very useful for postgraduates. So not much useful for undergraduate, but it's a postgraduate book and consultant book and learner after MS. It gives everything. You can, before going to surgery, you can always read this book. I will memorize your steps and do the surgery properly. Every topic, general surgery, gastroenterology is covered in detail, step-by-step with illustrations. And my SRB's atlas of tissue approximation, small book atlas, 100 pages, how to do the suturing, tissue approximation, including laparoscopic suturing with the video. It is covered. So any basic learners, suturing is very, very important surgical field as a skill actually. Dissection and suturing, so the two parts of the surgical skill. So that is also covered very well with videos. You can always go through that. And my website, please subscribe, all of you. Your daily lectures are there, live sessions are there. My digital lecture through JP Publishers, around 220-hour lectures. Entire thing as for CBM is covered with the examination part, with all topics of CBME, ulcer to operative surgery, instruments, specimens, examination, specialties, basic, everything is covered. You can always purchase for 1 year and have a clear idea about the surgical topics, understand very well and helpful for your exam, NEET, MCQs. Also, it is there both in manual and my lectures. So students, I hope you have understood this lecture very well. Thank you very much.